Good evening and welcome to my YouTube channel Pain Free Partha. Today's topic is about pediatric pain assessment. So last week we had adult pain assessment and today it is going to be pediatric pain assessment. So the most important problem is child cannot speak. Okay, I'm having a lot of intolerable pain. Such things many children cannot speak. That is a major hiccup in assessment of pediatric pain. Yes, if the patient tells I'm having this much of pain, then it is okay. Because pain is a subjective event. You cannot measure like blood pressure, pulse rate, pulse oximeter, saturation, or something like that. It is a self-report. So it is very difficult for the kid to think. So that we have two things: behavioral measures and biological measures. Okay, how the body reacts and what children do is biological behavior. Cry, vocalization, faces, all these things are behavioral, while heart rate, blood pressure, and the autonomic system problem is biological. Many times the baby cries because it's a stranger and fearing child. It is afraid of injections. So it is not exactly due to pain. That is what every time the patient's face is changed, patient is crying, baby. We cannot just assume that it is pain. That is another story of pediatric pain assessment. We know regular techniques, visual analog scale, numerical rating scale. These are acceptable only after 8 years. Some say it's around 6 to 8 years. It depends upon the IQ of the child. It is acceptable over 8 years. Lot of faces pain scales are available. Line diagram of faces with expressions, increasing distress. Now you can see this is out. There are a lot of scales. I will come to a conclusion how to corroborate everything in a simple way in the last. The outer is a poster developed. Here you can see 0 to 100. This is for adults. And this is for adults or semi-adults or big kids. This is for small kids. They can find out the picture and tell. This is Wong-Baker faces rating scale. This is a vertical, no pain. And see here, the face, no hurt, slight hurt, mild hurt, moderate hurt, intolerable hurt. So it measures in terms of hurt. Now you can see no hurt, little bit, little more, even more, whole lot, the worst. So this is about hurting, how the faces is. There are color coding even in kids, like veterans. The most important problem is Wong's faces rating scale is child has to tell, oh, this is my scale, this is my scale. That is the difference. Ask the person to choose the face. He will tell this face. Okay, this is something little more, something like 6.5 to 6 in the VAS score. Now you can see this patient is some 8 or 9-year-old child. Now you can see absolutely sleeping. You can see the biological markers are fine, sleeping. So the absolutely you can see the faces. Now I'm going to tell CHIOP scale, Children's Hospital Eastern Ontario Pain Scale. Why I am telling this again? CHIOP is an exam question for MDs. CHIOPS, CHEOPS, Children's Hospital Eastern Ontario Pain Scale. So this is about behavior, crying, face, how he is talking, how it is the activity of the limbs, and how he reacts to touch, and how it is reacting to lower lips. So it is about from 4 to 13 points. We should be able to know that it is 4 to 13 points. Children's Hospital Eastern Ontario Pain Scale. There is something called pain assessment tool. This is modified. So we have to check, observe. This is mainly for this is neonate. Color, facial expressions. Gently touch the neonate's lip. See the tone, gently touch. Physiological and behavioral parameters. Each item is 0 to 2, and then you assess in terms of the total score of 10. We can also give him the point. See, for example, this is the red point. This is maximum pain. This is another point where it is less pain. Color will differentiate where the pain is high and where the pain is less. There are innumerable scales. Pieces of Hurst scale, Manchester scale, Berry, Facey. Now, we will go to FLACC scale because it is important for studies, degrees, research, everything. Face, legs, activity, cry, and consolability. So how the child can be easily consoled. This is what is called FLACC scale. Now we can see face, legs, activity, cry, consolability. He is easily consoled, content relaxed. He can be reassured. It is difficult to console. This is 0, 1, 2. Legs are normal position, uneasy, restless legs. He is kicking and legs down leg. Activity, lying quietly. This is what we saw in the child. Some movement is there. Rigid, jerking. Cry, no cry. Some moaning is there. And crying steadily, screaming. So all these becomes FLACC scale. Face, legs, activity, cry, and consolability. Now, 2 months, 8 years, it can be used up to 18 years with cognitive impairment or developmental disability. It is difficult to assess children with cognitive impairment. They are non-verbal. They cannot speak. We have to ask the parent or a caregiver to ask. Now, how to use FLACC? We have to see the patient. We have to see the patient from 0 to 2 scale, face, legs, activity, all these things. The difference between Wong scale and FLACC scale is Wong scale the child tells. In FLACC scale the observer sees and marks. This is the difference between Wong scale and FLACC scale. Now we go to poker chips. Poker chip tool. There are a lot of tools like this. How much is the pain? The baby will pick up the maximum number of red chips. There is something called neonatal facial action coding system. 10 facial actions from the videotapes and find it out. How much is the pain? So these things are now coming up. Automated facial action recognition. We have adult automated facial action recognition. Similarly, we can give this. All these things are VGG network fine-tuned with infant ages. This is all about artificial intelligence. How this is made to this thing. This says action unit. Post-operative accurate pain assessment with artificial intelligence. There is something called neonatal infant pain scale, NIPS, facial expression, cry, breathing, arms, legs, how it is arousable. This is what is called the comfort scale. In adult also I have told. Sometimes the patient may be having pain, but if he looks comfortable or he looks comfortable, so that is somewhat different from pain scale. That's a comfort scale. People move towards comfort scale from pain scale in certain conditions. The University of Wisconsin pain scale, yes, cry, face, behavior, posture, sleep, and the FLACC scale. It all depends upon where is the patient, where is the kid. That is also important. Sometimes among strangers or among the parents. Now, if you go to this thing, 0, it is about coding. It's around 1 or 2 years, it's about hurting. Around 4 to 5 years, it's about face. And about 7 to 10 years, it is about visual analog score and NRS. So it's about 3 to 4 scores. So it's about hurting. So this is about coding. So that is how age and pain assessment from 0 to 10. These are all the common things which are used. Now we have special considerations for the cognitively impaired child, which is very difficult. Evidence safety, there are very less. We are afraid about the opioids. Outdated beliefs that these children have blunted pain perception. Yes, they have pain. Infants have pain, neonates have pain, children have pain, and cognitively impaired children have also pain. How frequently we have to check? This is a major problem, because somebody will say, I'm going to check 8th week. Somebody will say every 4th week. Very important in a child is, you should not wake up the child and ask, what is your NRS? You can ask your NRS when the child is awake. And you have to go to observational scores like FLACC scales when the baby is sleeping, face, crying, all these things you should go. This is what is very important. Yes, because it comes every 2 hours, we have to make the baby like. Then go on research 2-hourly pain scales. Go on waking up the baby is not ideal. So many wongs, FLACC, Oucher, Wisconsin, Schiop's, myths. What is important is pulse and blood pressure or biological changes. Face, sleep, breathing, cry and lips, or behavioral changes. If the patient's face is cool, not crying, limbs are relaxed, yes, the patient is not having much pain. If the baby's face is little grimy and is not calm, and the breathing is slightly like this, and having some increased tone of the legs, yes, pain. And the child is screaming with pain, doing all these things, yes, that is more. With a pulse rate and blood pressure of 140 per minute. So this is how basically we should ask. Every patient cannot see. From there we can see what is the face, what is the limbs, what is the activity, what is respiration, what is the crying, all these things. And go into the monitor to see what is. Now these are not techniques of reduction. These are measurement in pediatrics. Now we can see the operating now. This is not post-operative pain. See, the patient is being
நல்லா
with
இருக்கேன்.
spinal anesthesia.
ஏய்
Complete pain relief,
என்ன
not much
படிச்சுட்டு இருக்க?
sedation.
இல்லை அது பார்க்கணுமே என்ன செய்கிறாங்கன்னு
அது
என்ன
Some
செய்கிறாங்கன்னு
என்ன செய்கிறாங்கன்னு பார்க்க கொஞ்சம் நேரம் கழிச்சு பார்க்கலாம். கொஞ்சம் இது பண்ணுறாரு உன் லெவலுக்கு இன்னும் வரல அவரு. நீ சூப்பர்வைஸ் பண்ணுற லெவலுக்கு என்ன கொஞ்சம் பிக்கப் பண்ணி வருவார் அப்புறமா. ஓகே
now is so calm, nice. So if you get a patient like this in the post-operative ward, you can say the NRS is 0. Thank you very much for patient listening. Visit me at www.painfreepartha.com for all freely downloadable slides, and listen to Pain Free Partha in YouTube and comment. Thank you.